Chair of Division of Neurointerventional Radiology and Director of Neurovascular Center at the Leahy Clinic and Beth Israel Leahy Health in Boston, and a full Professor of Radiology at the UMass Chan School of Medicine. Focusing his research on efforts in imaging and treatment of neurovascular diseases, Dr. Krings has published more than 500 peer-reviewed articles, approximately 30 book chapters, and 4 books on interventional radiology, neurovascular anatomy, stroke management, and neurovascular imaging. Dr. Krings' leadership in the field of neuroradiology is bolstered by his distinguished grants and awards, including the Scientific Award of the European Society of Neuroradiology, the Lucian Apple Prize, and the Founders Award in Interventional Neuroradiology of the ESNR. He also received the Golden Medal of the British Society of Neuroradiology, and for his effort in the development of the neuroradiology program in Toronto, he won the Anderson Award of Whiteman Perry's Academy, and was also granted the Edward Lanson Award of Outstanding Teaching in the Residency Program at the University of Toronto. We are excited today for his talk about very important topics, tinnitus and imaging and management options. Welcome, Dr. Krings. Thank you so much for joining us today.
Thank you very much for this very kind introduction. I hope you see my slides.
Yes, we can see them.
Perfect. Okay, so today I will have the pleasure to speak to you a little bit about tinnitus, and being both an interventional and diagnostic neuroradiologist, we will move from the imaging component towards the management component. I will give you a little bit of the way that we are currently approaching this potentially devastating condition that afflicts quite a few number of patients worldwide. We will discuss a little bit about what are the different types of tinnitus and how can we differentiate them, and where are the ones where we as neurointerventionists, as endovascular neurosurgeons, interventional neuroradiologists, play a major role in treatment of these patients. There are no relevant disclosures in relation to the contents of this presentation. Now, as I told you, tinnitus is a very much so prevalent disease. In fact, it's present in up to 12% of the general population, more commonly in the elderly, and it's defined as a perception of a noise without an acoustic stimulation. So you can call it a kind of acoustic hallucination. There are different types of tinnitus, and it's important for you to identify in a given patient whether it's a pulsatile versus non-pulsatile tinnitus, whether it's an objective versus subjective tinnitus. The reason of this differentiation is of importance because the non-pulsatile tinnitus that is objective is very rarely something that we can treat with our endovascular techniques, and it would be more a patient that would move towards the ENT side of the triage pathway, as compared to, let's say, a subjective and pulse synchronous tinnitus that you can hear with your stethoscope and that is in a rhythm with the patient's heart. These are patients where very commonly we find a pathology that can be treated. And then, of course, there are the objective pulse synchronous ones. And here there are a couple of items that we can look at a patient in order to identify whether it could be a patient that may be amenable to our treatment options or not. Non-pulsatile objective one is extremely rare, and we will not move more into these very rare types of tinnitus forms. Now, when we are looking at pulse synchronous tinnitus, and this will be the first and the largest component of my talk, we'll have to differentiate causes that are on the arterial side, that are on the venous side, and that are related to temporal bone pathology. And you will be easily able to identify that, of course, the arterial and the venous causes of pulse synchronous tinnitus can be those that we can actually modulate with our endovascular techniques. So let's dive into the arterial causes of pulse synchronous tinnitus, and we will go through some imaging findings as well as some examples on how to treat them. So we'll start off with carotid stenosis. Now, carotid stenosis, we all know how they are looking like. We have here a high degree stenosis, obviously, of the right carotid artery. And the higher it is, the closer it is to the bone, and therefore the turbulent flow that can be present following like a very high degree narrowing can be transmitted from the vessel into the bone and can therefore lead to the perception of a sound. So, high degree stenosis, especially if this stenosis is relatively high up, close towards the bony structures, the foramen lacerum segment, can cause tinnitus, and of course, is definitely like something that we can treat with endovascular means, as we can see here, where we just simply put a stent, do a balloon angioplasty, and open the vessel, thus leading to less turbulent flow. Likewise, not only an atherosclerotic stenosis, but also a narrowing related to a dissection can cause tinnitus. Now, dissections can cause tinnitus because the area of a dissection is often at a location where the mobile segment of an artery enters into an immobile segment, i.e., where the carotid artery enters into the foramen lacerum segment. And in these areas, patients are more prone to develop dissections. Now, if you have a dissection, and especially if there's a flap within the vessel, then you can have like turbulent flow distant to it. And this turbulent flow is right smack where the like bony canal is, which can therefore cause to transmission of the sound, of the turbulent sound, towards the inner ear and therefore the perception of tinnitus. So here we have an example of a previous dissection. You can see that it's right inferior to the foramen lacerum segment, and these are patients that you can treat, for example, then with stenting. Here another example of a dissection with a typical Horner's syndrome on the right side with meiosis and ptosis and an irregular shape of the carotid artery that has caused this patient's tinnitus. Now, ICA dissections have a very common pathological mechanism. You either have a hyperextension with contralateral or lateral flexion, i.e., your classical chiropractic maneuver, or you can have a whiplash injury. Now, the whiplash injury causes the disruption classically more inferior, whereas this rotation in contralateral and lateral flexion is the typical mechanism of a dissection which is closer to the skull base and therefore is more commonly related to tinnitus. When can you have this hyperextension with contralateral and lateral flexion? I told you about the chiropractic maneuvers, but there are also other things like back here in Boston, it's snow shoveling, because during snow shoveling, you can have this type of movement, or like a vigorous golf swing, or like the angry father who reaches over and shouts to his children who are in the back of the car that they should better be silent. All of this leads to like this sudden contralateral flexion rotation injury that can be in hyperextension and that can cause dissection. And of course, we do know that tinnitus is but the least dangerous form of a dissection to become symptomatic, but it's something that you may want to think about. So here we had a patient who presented with a left-sided tinnitus. She was hospitalized for motor vehicle accident. You can see very nicely here the high degree stenosis, nearly disruption on the time of, on the contrast enhanced MRA related to this dissecting process at the foramen lacerum segment. You see that the patient had incomplete flow, and this can be treated obviously then with, for example, intracranial stenting if the patient needs to have this type of procedure. Now, The next arterial cause is a pretty uncommon one, and this is an aneurysm of the petrous ICA. Here we have a patient who presented with sensorineural hearing loss on the left side. He had a chronic otitis, tinnitus, and on imaging you could see that there was an aneurysm pointing right here into the middle ear related, therefore, to then turbulent flow, which caused the sensation of tinnitus. Here are the 3D reconstruction of the angiography. Often these types of aneurysms are pseudoaneurysms. They can be present after, for example, an ENT surgeon did a biopsy for pulsatile mass. And of course, these are then potentially causing significant problems other than tinnitus, including bleeding from the ear, which would warrant emergency treatment. So in this case here, given that there was no bleeding, we were thinking about how best to treat this type of tinnitus, and we thought that we will just have to decrease the flow in the aneurysm. So in this case here, a flow diverter treatment was performed that led to stasis within the aneurysm, and the tinnitus indeed went away. Okay. Now, let's talk about other causes on the arterial side for tinnitus. And here we'll have to speak about anatomical variations. And this is the persistent stapedial artery and the so-called aberrant course of the ICA. The aberrant course of the ICA means that the ICA courses through the posterior middle ear, through a dilated inferior tympanic canal anteriorly over the promontorium, and it will then end in the petrous portion of the horizontal carotid canal. So from an imaging perspective, you will see a far lateral course of the proximal portion of the ICA and a prolonged horizontal course of the ICA while it's looping back into or via the petrous portion into the horizontal carotid canal. On CT or CTA, you will be able to see the dilated vessel going along the promontorium. And on the angiography, here in MR angiography, you see the far lateral course of the ICA and the prolonged horizontal course as your classical imaging of the aberrant course of the ICA. Sometimes, as I said previously, the ENT surgeon looks into the ear and he sees a bluish or reddish pulsating mass. And of course, this would be a contraindication for biopsy because you would biopsy the aberrant internal carotid artery here. Another example here that demonstrates the aberrant internal carotid artery on these subsequent images. Here, there is absence of your normal carotid canal. You can see the normal carotid canal right here. There's absence of it right there. And instead, there's the course of the ICA through the inner ear. The persistent stapedial artery is another anatomical variation where the middle meningeal artery arises from the stapedial artery at the level of the vertical portion of the petrous segment of the ICA. You can see right here, there's the ICA, and there's an artery arising from the ICA right there that is then coursing through right there the inner ear, being in very close contact, therefore, to the landmark structures that will lead to conducive like tinnitus. And here you'll see the angiography where the persistent stapedial artery arises from the ICA, gives rise here to the middle meningeal artery that then supplies the meninges. Of importance, of course, for us when we are now treating more and more patients with chronic subdural hematoma, always have a look at the like normal bony anatomy to see whether you have this type of anatomical variation, which will not preclude you from chronic subdural hematoma embolization, but which will make your life a little bit more difficult, and treatment, especially with particles or liquid embolic, more dangerous. Okay. Now, let's talk about like a combination of disorder of the bones and arterial causes, and this would be the dehiscence of the cochlea. Normally, the ICA is covered by like a bony margin. However, if you have an associated dehiscence of this bony margin towards the cochlea, then even the normal course of your carotid artery can lead to a tinnitus sensation because the bone is no longer present and therefore the pulsation of your carotid artery can be transmitted. All of these arterial causes that I have just described typically get worse with exertion or with high blood pressure and get better overnight when the blood pressure is actually dropping. So this is something that will help you to differentiate whether you will have an arterial cause or venous cause of your tinnitus. And here's just another example where we see very nicely the dehiscence of the bony anatomy as compared to your normal carotid artery in relation to the inner ear. Then there was the question whether an intrameatal ICA loop can cause tinnitus. And there's a lot of discussion in the literature because obviously these right-sided ICA loops that sometimes even can like lead to distortion of your seventh and eighth cranial nerve within the internal auditory canal can be present in quite a significant number of patients. And since the prevalence of tinnitus is 12%, many radiologists put one and one together and said, well, maybe it's the ICA loop that is leading to compression of the nerve and therefore the sensation of a sound. This has been questioned, however, and this was very recently in this article here published in the American Journal of Neuroradiology, where this theory was very clearly refuted because there was no significant association between the ICA loop and tinnitus or sensorineural hearing loss in this like meta-analysis of multiple studies. So therefore, I do not believe that a persistent ICA loop can cause indeed tinnitus, and it should be kind of made or like dropped off of your list of differential diagnosis for arterial causes. Now, let's speak about one of the most common and treatable causes of arterial tinnitus, and these are arteriovenous shunts, arteriovenous malformations, and in particular the dural arteriovenous fistulas. Now, here we have a patient with a high flow pile arteriovenous malformation, and you can clearly identify that the high flow, especially since it's going towards the like transverse sinus, can cause turbulences and can therefore cause tinnitus. But it's not only the high flow that can cause tinnitus, but it can also be the turbulences related to stenosis at the transverse sinus level. So here we have a patient who presented with tinnitus, and obviously the AVM being in the posterior corpus callosum, it's difficult to like identify why a patient should have like a tinnitus. But when you look now at the time resolved MR angiography, you can see that this patient's AVM has led to bilateral significant transverse sinus stenosis. And now you have a transverse sinus stenosis in association with like higher flow or arterialized flow. This can again cause tinnitus, as in this patient here. So when you have a patient with pulse synchronous tinnitus, especially if it's getting worse, if the blood pressure is getting higher, look also for AVMs elsewhere, not only draining into the transverse sinuses, but in this case here, the high degree stenosis may have led to turbulent flow and therefore the occurrence of tinnitus. High flow, such as in patients with vertebrovenous fistulas, can cause tinnitus. You see this patient here had many years ago trauma and now has this remodeling of the bone due to a long-standing high flow vertebrovenous fistula going here into the venous plexus that then drained all the way towards, even retrogradally, the mastoidal veins, therefore causing the tinnitus. The teaching point here is, if you have a patient with tinnitus, it is not sufficient to only visualize the cranium, but you should visualize all the way down to the head and neck region, as sometimes neck vascular malformations can drain retrogradally towards mastoidal nuchal veins and therefore cause the sensation of tinnitus. Here, another example of a patient who had a collagenopathy. In fact, it was a neurofibromatosis, which affects, due to a disorganized media layer, the blood vessels, especially of the medium large arteries, so the vertebral arteries, that makes those arteries more prone to developing arteriovenous fistulae. And if the fistulization is into the vertebral plexus, then you have a vertebrovenous fistula, as in this example here. You should not mistake this in a patient with fibromatosis, as it is an enhancing mass within the neuroforamen with a neurofibroma. But think about also the possibility of these patients having fistulas. Now, let's talk briefly about dural arteriovenous fistula. It's like my pet topic, and I won't go into greater detail here, but I will want to speak a little bit about the classical imaging findings in dural arteriovenous fistula, as this is something that can cause pulse synchronous, often objective tinnitus in patients. And what we'll have to look for are a couple of things. We'll have to look for dilated ECA branches. Look at the occipital artery on one side here as compared to the occipital artery on the other side. Look at dilated transosseous branches. Look at these shaggy sinuses that are in close proximity to the bone here. Another example where you see too many blood vessels going through the bone, in this case here on the right side as compared to the normal left side. Too many abnormal blood vessels within the region, in the suboccipital region. These are findings for potential dural arteriovenous fistula. As I said, the so-called shaggy sinus sign on T1 post-contrast or time of flight MRA, as well as T2 weighted sequences, demonstrate a cluster of abnormal vessels surrounding the sinus, which are a sign for a dural arteriovenous fistula. If you have cortical venous reflux, of course, you will see the massively dilated sulcal vessels. So you don't see a parenchymal nidus, but the vessels are present within the sulci and that are abnormal there. And sometimes these sulcal vessels can be relatively difficult to see. There can be very small. So I blow this picture up for you. You see, this is the normal hemisphere on the right side, and on the left side, you see corkscrew-like pseudophlebitic vessels that are traversing the gyri as a sign for like dilated veins surrounding the sulci as a sign of cortical venous reflux. Sometimes, if you have cortical venous reflux, it can be so pronounced that on susceptibility weighted sequences, you even see dilated transmedullary veins. I like to look at just T2 TSE sequences. If you see too many vessels there, there's a high likelihood that the patient has a dural arteriovenous shunt. T2 is good, T1 post-contrast is better, but susceptibility-weighted sequences are the most sensitive to identify this cortical venous reflex. And sometimes you may even be able to see the arterialization of a vein. Here you see the dilated lateral paramesencephalic vein. A vein should have deoxygenated hemoglobin. If you see an oxyhemoglobin signal, i.e. a bright signal within the vein, you know that this vessel is arterialized, so you can directly identify here the arteriovenous shunt into, in this case here, the lateral paramesencephalic vein using susceptibility weighted sequences. Sometimes the findings of dural arteriovenous fistula can be very subtle. So in this case here, we just see a dilatation of your torcula. It's a subtle finding, but in a patient with pulse synchronous tinnitus, it should lead to further investigation, including in this case here, a DSA that indeed demonstrated the fistula. Here we had a patient who presented with tinnitus and cognitive decline, and he was relatively young, 42 years old. And you see, for a 42 years old patient, this is not your normal like flare hypersignal. It's definitely too bright. It's too confluent. This is not a morbus Binswanger vascular leukencephalopathy. This suggests a venous congestive type of disease. And if you then also see dilated transmedullary veins, as in this example here, you should make the diagnosis that this is venous congestion related to dural arteriovenous fistula, especially with the clinical history of pulse synchronous tinnitus. Subcortical calcifications, as in this example here, can be assigned for tinnitus, and sometimes these are localized, as in this example here, where we see the cortical venous reflux, the pseudophlebitic pattern, and the focal calcification as a sign of a dural arteriovenous fistula. Patients who have tinnitus and had a previous history of sinus thrombosis, in fact, you can see the missing flow void here in the transverse sinus, in addition to this shaggy sinus, are at a high risk of developing dural arteriovenous fistula. So this type of clinical history is of importance when you're looking for potential dural arteriovenous fistula. I like time of flight MRA because it can lead to the so-called unsaturation of spins, which means that all of the spins that are normally saturated, i.e. that go from cranial to caudal, are not visualized. But those spins that go from caudal to cranial, i.e. that do not see the saturation pulse, they are bright. And therefore, if you see a bright signal in a vein that should get its tributaries from cranial, where everything is saturated, then you know that these tributaries here have to come from caudal, i.e. have to be arterialized in order to make the signal bright in this time of flight MRA. If you want to get fancy, you can use dynamic MRA or dynamic CTA, where you inject contrast and then do multiple images over time. And if you see in an early arterial phase already filling of a vein, you know that the patient has a shunt. Bulging cavernous sinus can be a sign for dural arteriovenous fistula, or dilated superior ophthalmic vein, as in this example here. If this is present in a patient who also has pulse synchronous tinnitus, then you do know what the diagnosis is. Finally, if the tinnitus goes away, it's not time to pop champagne. It may actually be that the patient has occluded his outflow and therefore has made his dural arteriovenous fistula from a benign one into a malignant one. So change in tinnitus characteristics in a patient with known dural arteriovenous fistula should prompt you to perform further imaging. And here's one more example where we can see, like again, the isolated sinus and the backflow causing this patient's tinnitus that can then be treated, of course, via transarterial ways or via transvenous ways. There's one dural arteriovenous fistula that very commonly presents with a very severe tinnitus, and these are the dural arteriovenous fistula of the anterior condylar confluence, and these are often fed by the ascending pharyngeal artery. Since the ascending pharyngeal artery has a lot of collaterals to the to both the vertebral artery and to the internal carotid artery via the meningohypophyseal trunk and the clival arteries, an intraarterial treatment is contraindicated for those types of condylar confluence fistulas. but a venous treatment is indicated. And in these cases, you can go from the jugular vein, point your catheter posteriorly and medially, get into the confluence of the anterior condylar vein. This is highlighted here. And then just with a couple of coils, you can close off the fistula without compromising the normal blood flow to the ascending pharyngeal artery. So, as I said, we will not go into details here of the management of dural arteriovenous fistula. It's just to tell you that you can use transarterial routes, you can use transvenous routes, and depending on the location of the fistula, one or the other may be preferable and may be more safer. Bottom line is, when we are talking about arterial causes of tinnitus, there are a couple that you can treat: the carotid stenosis, the dissections, the aneurysm of the petrous ICA, and the arteriovenous shunts. The other ones, I think you'll have to be just aware of and make sure that the ENT surgeon will not go towards like biopsies of these types of lesions. And I think we can be relatively safe in saying that the intrameatal ICA loops are not a cause of tinnitus. Now, these were the first causes, the arterial causes. Now let's switch gears and speak about the venous causes of tinnitus. They are often presenting slightly different. In most cases, these are not objective types of tinnitus, i.e., you can't hear them, but it's more a subjective one. It's interesting that the patients say that with certain head positions, the tinnitus can get louder or actually less loud. And the best way for you to identify whether a patient has a potential venous cause of tinnitus is a very simple trick. You just take your hand and you compress behind the ear, below the mastoid, where your jugular vein would be. And you do this on the side where the patient has the tinnitus and on the side where the patient does not have the tinnitus. And if the patient's sound gets louder when you compress the contralateral side, and if the sound gets less loud if you compress the ipsilateral side, then you know that the patient has likely a venous cause of his tinnitus. And if this is the case, then you may be able to find on imaging one of these pathologies here, some of which can actually be very much and readily treated via endovascular means. So let's go through the venous causes of tinnitus. First one being the high riding jugular bulb, often associated with a focal dehiscence. So this is an anatomical variation. So there's very little that you can do because the patient obviously needs his jugular bulb. Often it is in patients who have a dominant venous system on one side, and of course you can't close it. But sometimes even telling the patient, okay, we can't help you, we can't treat you, but we have at least found the cause. Sometimes at least this gives some form of solace to the patient. So a high riding jugular bulb above the inner ear, which has thinned the bony floor to the middle ear, can cause tinnitus in patients, a typical venous type of swooshing sound. Here, another example where we can see very nicely the thinning of the bony floor towards the middle ear due to this high riding jugular bulb. Sometimes the missing bone can be quite significant. Here we have a complete bulbous dehiscence with the missing bone. Here another example where it's not as prominent. And here are cases where you may want to discuss with your ENT surgeon, as there are nowadays possibilities to cover this dehiscence by open surgical ENT means to treat these patients. The dehiscence can not only or does not always have to be towards the middle ear, but it can also be a dehiscence towards the superior semicircular canal, as in this example here, that can cause tinnitus. Here, another example where we have a high-riding jugular bulb and this nicely depiction of the dehiscence to the posterior semicircular canal here. These are findings that your imagers, your neuroradiologists, your diagnostic neuroradiologists have to find. And what we have very good experience here at the Leahy Clinic is that we have a template for patients who come in with a clinical history of tinnitus, where the neuroradiologists have to go step by step and say, do we have A, B, C, D? And they say yes, no, yes, no. And this helps obviously to have a structured form of reporting to identify where and whether one of those findings that can cause a tinnitus are present. Okay. Now, the next anatomical variation is if you have a very dominant transverse or sigmoid sinus as compared to contralateral side. So this was a patient who had right-sided tinnitus, and we looked far and wide, and we couldn't see anything else but that her right side was more dominant as compared to her left side. And we said there's very little that we can do from our perspective. There's no dehiscence here, there's nothing, no stenosis, but we believe that this is causing your tinnitus. And even this knowledge helped actually the patient to cope with her tinnitus, which was not the worst one of some of the patients that we've been seeing. Venous outpouchings. Now, venous outpouchings are distant from your high-riding jugular bulb and can really look, as in this example here, as focal venous aneurysms. And these aneurysms or focal outpouchings can thin the wall, can lead to turbulences, and maybe it's actually the turbulence that makes the thinning of the wall or the progressive growing of this outpouching. And therefore, these are often patients where, with increasing age, the tinnitus actually gets slowly but progressively worse. That they said, oh yeah, I suffered from tinnitus for many, many years, but over the last couple of months or years, it has gotten progressively worse, and I can't sleep now any longer because I constantly hear this sound. That is something where you may think about a progressive venous outpouching. And of course, they do not bleed, but they can cause, due to the turbulences, this significant tinnitus, and they can be treated. Let me show you here an example of a recent case that we treated after I speak here about idiopathic intracranial hypertension. Now, IIH, as we know, is a disease of young female patients who are often overweight. They present with headaches, they can present with visual loss, and they can present with tinnitus. On imaging findings, we can see the classical findings of an empty cellar right there, of dilatation of the optic nerve sheath. Sometimes we see tortuosity of the optic nerves. We can see dilatation of Meckel's cave. All of these being signs for increased intracranial pressure. And the pathophysiology of this IIH is not completely known. What we do know is that from an imaging perspective, they also have bilateral transverse sinus narrowing. And now you have to ask yourself, what is the chicken and what is the egg? Do we have bilateral transverse sinus narrowing, therefore decreased venous outflow, therefore increased venous pressure? Or do we have first increased intracranial pressure that compresses the vein? No matter what is the chicken or what is the egg, it is definitely a vicious cycle. Because if you have these venous stenosis, you will have an increased intracranial pressure, which will lead to even further worsening of your venous systems. Recently, it has found that it may actually be something else that triggers this idiopathic intracranial hypertension. Therefore, we have to now very briefly also move towards the thought process of what is happening with aquaporin force and the glymphatic system. Before we go into these high-level details, couple of slides on how to treat patients with IIH. The first line of treatment is Diamox. If Diamox doesn't work, then the next line of treatment, actually the first line of treatment, sorry, is weight loss, changes in lifestyle, etc., so as to decrease your body habitus, which is causing likely, as I will discuss a little bit later, IIH. If this doesn't work, it would be Diamox. If this still doesn't work, or if the side effects of Diamox are not tolerable for a patient, then we can either think about open surgical approaches such as shunting or optic nerve sheath fenestration, or something that is way less invasive, and this is venous stenting. And venous stenting is something that can be done relatively straightforward without great risk. We can put a stent into the venous system, open the blood vessel, and therefore stop the vicious cycle from happening. Because now that you have increase the outflow, your intracranial pressure will actually decrease and the patient's symptoms will get better. And this has not only the effect of resolving the headaches and the papilledema, but in this case also the patient's tinnitus went away. And there are a couple of articles, this one from our group, that demonstrated that indeed venous sinus stenting is a feasible treatment for patients with IIH. But as I told you, this is not the entire story because IIH is way more complex and we may actually be barking up the wrong tree because maybe we are only treating the end product of an IIH. And so in recent years, there has been more work being done on the so-called glymphatic system. And I think I will speak about the glymphatic system in a future talk here at the Seattle Science Foundation. So stay tuned on this. But what the glymphatic system is briefly doing is it's a waste clearance system where we have convective flow from the perivascular spaces through the interstitium into the veins. And this is regulated by the aquaporin 4 channels. And if these are dysregulated, and we now know that they can be dysregulated due to, for example, chronic inflammatory processes, such as being present in being chronically overweight, you will have less of an CSF efflux and therefore a glymphatic congestion, which will be the cause of your increased cranial pressure. Likewise, the chronic inflammation can cause, due to activation actually of the aquaporin 1 channels, to an increase of the CSF production and therefore to raised intracranial pressure. So our current understanding of IIH is a little bit more like going into like where exactly it is affecting the glymphatic outflow theory. And what we are doing with putting in a stent into the venous system is we are kind of putting a band-aid onto a bleeding wound. It may give us some relief, but not for the long term. And I do believe that maybe in the future we will have better options in increasing actually the aquaporin 4 malfunction or working on this component of IIH. But for the time being, venous stenting is still a pretty good treatment option. And there's something else that this IIH taught us about venous stenting and tinnitus. It taught us that, well, the tinnitus may be related to a patient having turbulent flow. And this turbulent flow can cause the sensation of a sound. So maybe, therefore, in patients who only have tinnitus without having raised intracranial pressure, but where we do see a high degree stenosis, we may be able to treat them by just opening up the vessel by making the flow more laminar. So here we have a patient who had right-sided tinnitus, no other symptoms. The left side looks completely normal, but the right side is narrowed. And the question is, could this narrowing cause turbulences and therefore the tinnitus? And can we treat it? Well, for sure we can treat it, but we'll have to be also sure that this is what is causing the tinnitus. And this is where nowadays computational fluid dynamics may help us. Now, here we have another patient who had right-sided tinnitus. And the thing that we saw was this dilated Pacchionian granulation pointing into the transverse sinus. So what we did in this patient is we were segmenting the transverse sinus, the sigmoid sinus, the jugular bulb, and the jugular out. So here we have a lateral view of the proximal transverse, the distal transverse, the sigmoid, and the jugular with the Pacchionian granulation. And then we used computational fluid dynamics to calculate how would the flow be within this vein due to the stenosis. And then we can make this movie that demonstrates where we have the highest flow, where we have the most significant vortex scores, i.e. turbulences, and then we can give to each turbulences a pitch. What you're hearing here is a computer-generated sound related to the pitch that we conduct from the amount of turbulences based on this patient's computational fluid dynamics. And when we played this to the patient here, he said, she said, this is exactly the sound that she's hearing. So we realized that in all likelihood, this was indeed this stenosis was indeed causing this patient's tinnitus. And this is now the patient after we put in a stent. And we can see now that the flow is completely laminar, that there are no vortices, and therefore there's actually no sound. You could even simulate this prior to putting in the stent to identify whether your treatment will be successful or not. Now, venous stenosis can actually cause outpouchings. And this is the case that I wanted to show you a couple of slides earlier. This was a patient who had this venous outpouching pointing towards the mastoid. Patient had a right-sided tinnitus that got progressively worse over time. I'm sorry. And we saw that this patient had a high degree stenosis of her right transverse sinus right here, just proximal to where this outpouching was. And we believe that in this patient, it was likely that the outpouching was related to the increased turbulences because of the focal stenosis. So what we decided to do in this patient was here is the outpouching. We did a biaxial approach. We put a microcatheter into the outpouching. We deployed a stent to open the narrowing, and then we coiled off the outpouching that you can see nicely here. And the patient woke up and said for the first time in years, she has no longer any tinnitus. So it was kind of an immediate effect in this patient here. Now, finally, anatomical variations can cause tinnitus. So if you have, here, a hypoplastic jugular, but your main outflow is going you through mastoidal veins, this can cause like the tinnitus. And of course, you should not take this main outflow route here because then the patient would have venous congestive problems. Here, another example of a non-dominant mastoidal vein that's still presented with tinnitus. And here the conduit is via the posterior condylar vein right there, going into these nuchal veins that are in close proximity here towards the mastoid. So, to summarize the venous causes of tinnitus, there are quite a few that you can treat with endovascular means nowadays, including IIH, venous stenosis, and venous outpouchings. the final portion of my talk, temporal bone pathology. And here, of course, we'll have to talk about the glomus tumors, as they can cause often a non-pulse synchronous tinnitus. And as I said, this is a very rare disease. So given the lack of time, I will jump through it a little bit faster. On imaging, you will find a sessile mass with a broad basis towards the promontorium. They are rare, but within all head and neck tumors, only 0.6%. They are the second most common tumor, however, of the temporal bone. They are the most common neoplasm of the middle ear, which is of importance to realize, the tympanic paraganglioma. Temporal origin is present in 50%, 50 years of age. In younger patients, you have more rapid growth. There's a female preponderance, and it is most commonly seen in patients who live in high altitudes, for example, in the Andes. Whether it's a glomus tympanicum or glomus jugulare depends on where the mass starts off with, so whether it's the cochlear promontory or along the adventitia of the jugular bulb. But then when it's getting to a certain degree, it's really difficult to differentiate, and therefore this term of glomus jugulotympanicum tumor was made. From a clinical perspective, in the early stages, you still have tinnitus. However, the longer you wait, the less you have the tinnitus, because now the bone is getting progressively eroded and destroyed. So disappearance of the tinnitus actually suggests a cochlear destruction, and then the patient will present with hearing loss rather than tinnitus. The classification of the paragangliomas is according to the Fish and Valavanis, i.e. the Zurich classification. And without going into it, here a couple of examples of this sessile promontorial mass, often a salt and pepper appearance of a densely vascularized mass that can cause tinnitus. Cholesteatomas can cause tinnitus. It's a soft tissue in the tympanic cavity with bony erosion, as in this example here. And finally, very rarely, hemangioma of the facial nerve can cause tinnitus. And these are like true zebras, i.e. extremely rare cases. Non-pulse synchronous tinnitus. This is not our rearm, obviously. Here there's very little that we can do, but these are the findings, at least from an imaging perspective, that you'll have to look for. The dehiscence of the semicircular canal, as in this example here. You can have here dehiscence right there, up there. This is the normal bony covering. You can have a large vestibular aqueduct syndrome. Here you see the large vestibular aqueduct right there, which can cause sensorineural hearing loss and tinnitus. Here you have a patient with a vestibular schwannoma that can cause tinnitus. Right there is the vestibular schwannoma. You can have patient with Lhermitte-Duclos or Ramsay-Hunt syndrome. So here is an example where we have like another, vestibular schwannoma on the right side. Lhermitte-Duclos or dysplastic gangliocytoma can present with tinnitus. Ramsay-Hunt, infection of the facial nerve, often seen with contrast enhancement. Here is a sign for tinnitus. MELAS or fibrous dysplasia. All of these are non-pulse synchronous tinnitus types. So, last 5 minutes, our imaging strategy. If you have a patient with a non-pulsatile tinnitus, ask whether the patient also has hearing loss. If it's sensorineural hearing loss, you'll have to go for your vestibular schwannoma, i.e. do an MRI with your IAC protocol. If the patient has conductive hearing loss, you'll have to do a CT of the temporal bone, because the most common cause is canal dehiscence. If a patient has a pulsatile one, these are the ones that we are focusing on from a neuroendovascular perspective. Is it objective? Can you hear it? Put your stethoscope behind the mastoid. You hear it. The patient hears it. Well, then you'll have to go at least for CTA or even directly towards DSA, because this is what we are looking for. These are the patients that have a high likelihood of harboring a dural arteriovenous fistula that can be treated, obviously, with our means. If it's a subjective pulsatile tinnitus, my first step would be to tell the patient to compress his jugular on the ipsilateral and on the contralateral side to see whether there's any change. And especially if the patient's noise goes away after he or she compresses her jugular vein, then you know it's likely a venous cause. So what I like to do from an imaging perspective, I like to do a CTA, but both in the early and in the venous, i.e. late phase, 20-second delay. And I like to have it reconstructed in the bone window, because this will allow me now to identify most of the causes that I just described to you. The CTA can look for arterial causes. The CTV can look for venous causes. And your bone windowing can look for the temporal bone pathology. So this is what we are asking now our neuroradiologists to put into their report. They have to kind of tick those boxes. Do we have any of those? Because remember, there are quite a few that we can treat with our endovascular means. So here are the endovascular options. Of course, arteriovenous shunting disease, dissections, IIH, venous turbulences, the diverticular, and the paragangliomas. These are all endovascular treatments. And with this, I would like to thank you very much for your attention. I would like to thank the organizers of the Seattle Science Foundation for inviting me. But most importantly, I would like to thank my team here at the Leahy Clinic of dedicated neuroendovascular specialists, nurses, technologists, nurse practitioners, and of course, physicians, Dr. Patel, Dr. Oru, and Dr. Pace. Thank you very much.
Timo, that was great. Thanks once again for joining us. It was a real tour de force. And I think this is a great resource that, we record these, and this is going to be compulsory viewing for our fellows at the start of every year, I think. One technical question on the venous stenting. Are you measuring pressures before and after? Which stent are you using? We've not seen in-stent or para-stent stenosis, but it's obviously been reported. And I just wonder whether it's the stent that people are using. We've tended to use the precise stent and haven't had that issue, but it's certainly been reported around the world. So just a couple of technical questions on that. Thanks.
Perfect. Thank you so much. And poor fellows having to go through this 1 hour talk. No. So regarding your questions as to what stent, I do like the precise stent. It's a very good stent. However, it was not made for the venous system. So sometimes what my problem with it is that it may not be long enough. I do like to have a longer stent. And there are now a couple of companies out there, and again, I have no disclosures there, that make stents that are dedicated onto the venous system. But yeah, what I do like about the precise stent, it does not appear to have the same amount of like in-stent stenosis that has been reported. And similar to what you described, I have seen it extremely rarely that we do see venous thrombus or venous stenosis. I think what is important is, and that's I think the main danger is when you're navigating into the venous system, make sure that your wire is in a J so that you're not getting hooked into the cerebellar veins. If you have any resistance, you may actually be in one of those venous pouches. Remember that the veins are not like your arteries, they have septa in between, and you may actually enter into one of those septa. And so don't force yourself through it. That's one important feature. Be very gentle when you're going through. And what I always tell my fellows is, I like the wire to be in J, and I really like them to continuously rotate so as to not get caught into one of those venous diverticula when you're doing the venous stenting. Now, this is regarding the technique and the type of stent. Your first question, I do apologize, was related to
The pressure measurement.
pressure
Pressures.
measurement.
Yeah,
Yeah.
the gradient. Obviously, I work with Cameron, so I still do it. But are you guys still doing that or no?
So we have stopped doing it because if I see a patient who has a stenosis, who has who where the where the sound goes away after you compress it, I'm actually not treating a pressure. I'm treating the turbulences. And so, therefore, in these types of patients where I'm only treating the tinnitus, I do like to just like make things fast and simple, and I don't do pressure measurements. In patients with IIH, it is a little bit to show the efficacy, but whether it is truly necessary, I'm not 100% sure. And I would love to have Cameron's input there. What do you think, Cameron?
Um, it becomes an issue of we don't really know what to do with the numbers. We don't know what the threshold number is, and so that grayness of that is a little bit of a problem for me. And I also have found a lot of inconsistencies in the measurements, so I don't think they're especially accurate. I think the gradient's probably accurate, but a lot of times I find that your baseline is, maybe 5 points off.
Yeah.
You change something and then suddenly it's 5 points difference, and it's kind of going, the eye roll that how much do you trust those numbers? So I mean, I like to see a gradient because it gives me a little bit of confidence that I'm treating the right pathology. But I'm not, despite what Steve says, I think he could keep his job here even if he didn't measure the pressure gradients.
Good for you, Stephen.
No more gradients. Just as a follow-up to that, Timo, a lot of people are stenting jugular veins and kind of getting further and further away from the kind of, should we say, on-label or more common venous stents. What's your take on jugular venous stents? Often you'll see a styloid that's pushing in on the jugular or something like that, and without intracranial stenosis. Are you guys pushing the envelope on those types of cases, or how do you feel about them?
So I think the jury is still out there. Dr. Fargan and Dr. Hui, who have a lot of experience on this subject, have recently published an excellent article in the Interventional Neuroradiology journal, where they are describing this jugular outflow or jugular obstruction theory as one of the causes of tinnitus or even of IIH. I think that that we definitely need more data, maybe even registry data. I do remember quite vividly the times of the liberation procedure for multiple sclerosis, where people started stenting the jugulars with very little avail and with potential risks. So I think we'll have to be sure that there is indeed like a pathology there that can be related to the patient's symptoms. Now, unfortunately, tinnitus, headaches, these are soft symptoms. And we see a lot of venous variations. And if you now put both together, especially if this is now a treatment that has a very low risk, there is a certain risk of over-treating patients with our techniques. And I believe that it's important for us to stick to hard data, make at least registries, if not prospective controlled trials, to identify whether this a relatively new area, i.e., going down below, has indeed an effect, as it appears to have based on the initial publications from these highly very like individuals that I highly respect.
Thank you.
I think
Can I
there
ask
are
Timo about thresholds for angiography? When I sometimes see a patient with pulse synchronous tinnitus, and on the non-invasive studies, I'm not identifying a source, and ultimately the question becomes, are you missing a small dural fistula? And most of the time, any fistula that's large enough to cause turbulence, you're going to see on the non-invasive studies. But every once in a while, I find myself in a little bit of a dilemma where I'm reassuring a patient that there's nothing to worry about, there's nothing dangerous. But without the catheter angiogram, I always feel like, is it possible you're missing a dural fistula?
I think it's a judgment call, like everything in medicine. There's no black and white, and medicine in the end is an art and not an exact science. And you are the artist, which means that you are the one who makes the decision depending on the entire spectrum. If I have an 88-year-old who can live with his tinnitus and whose vessels are really rotten, I would be hard pressed to perform an angiography. If, on the other hand, I have a 23-year-old with like straight vessels and he or she is really bothered by her tinnitus and I haven't found anything, and she says like, yes, I can hear it, it's pulse synchronous, I can hear it, then maybe like the one area that I would be like presumably then most looking towards would be indeed the anterior condylar arteriovenous fistula, because they very rarely have cortical venous reflux, and they can be difficult to identify because they are going into nuchal veins, and you can often have like a discrepancy of your nuchal veins just in normal individuals. So bottom line is, I think there will be rare instances where I believe it's necessary. Back in Toronto, we had with Richard Farb being one of the like godfathers of non-invasive vascular imaging, the possibility of doing time-resolved MRA or time-resolved CTA. I think this is also a nice method, but we have seen very small fistulas that we were not seeing on those types of techniques. So for a small group of patients, bottom line is I believe that there's still um, an indication for like truly invasive imaging, but it's just judgment call.
Radwan, did you want to? There's a question in the chat there, I see.
Yes. So there's a question about the focal venous stenosis that's usually caused by arachnoid granulations and get worse over the year. The question is there any explanation why those granulations enlarge over the years?
So first of all, I would like to thank Dr. Ichang Su from Taiwan to be online. He's one of my previous fellows, so hi to Taiwan. So I think that it's not necessarily the Pacchionian granulations who may increase over time, but as I showed in this case, the venous outpouchings, I think, may increase over time. I don't think like then again, Pacchionian granulations are not present in childhood or in young infants, so they do grow over time, or they do kind of sprout over time. So I believe that this is something that can be seen, but whether or not they are indeed relevant to the tinnitus would be related, in my opinion, to these like tests that you can do easily with a compression of the vein. And the other question that he asks is, when you see multiple bony etiologies concomitantly, what do I go first? I'll go from least invasive to most invasive. So I would definitely, before I do a sigmoid plate resurfacing, i.e. open surgery, I would presumably discuss with the ENT surgeon whether my endovascular treatment will in any way, shape, or form prevent him or her from doing further treatments. And if this is the case, I would be maybe reluctant. But if it does not have an effect on the subsequent potential surgery, I would go from least invasive to most invasive.
Thank you.
I think we've kept you beyond the time agreed. I really appreciate you being here. It's always wonderful to spend time with you, Timo, and I always admire your beautiful images, the meticulous attention you pay to the imaging and the teaching. It's easy to see why you have won awards for your teaching, because it really shows every time we have you. So thank you so much. Again, all the best to you, and I hope you have a great day.
Thank you so much, Cameron. Thanks, Steve, and thanks, Rod.